Hi, welcome to the NEET PG Core Revision series in Pharmacology, where I will be talking about the antimicrobials, and in that we'll be discussing about the cell wall synthesis inhibitors. Okay, so first let's classify the important antimicrobials based on their mechanism of action. So the first group we have the ones which inhibit the cell wall synthesis. So we have the penicillins, cephalosporins, vancomycin, bacitracin, and teicoplanin. Then the ones which target the cell membrane, we have azoles, polymyxin B, colistin, bacitracin. Third, the ones which target the protein synthesis, aminoglycosides, tetracyclines, macrolides, chloramphenicol, linezolid, clindamycin. Then the ones which inhibit the metabolism like sulfonamides, trimethoprim, pyrimethamine, and metronidazole. Then we have the other mechanisms, for example, suppression of DNA synthesis like it is by rifampicin, inhibition of DNA gyrase, that is by fluoroquinolones, inhibition of DNA or RNA polymerase by anti-cancer, antiviral drugs, and the drugs which directly can cause DNA damage like metronidazole. Now, out of these drugs, remember that most of the cell wall synthesis inhibitors, they are actually bactericidal in nature. Okay, so the ones which inhibit the cell wall synthesis are cidal in nature. So out of the second group, which causes distortion of the cell membrane, again these three ones, these are cidal in nature, while azoles are static in nature. Now, in contrast, the drugs which inhibit the protein synthesis, most of the drugs, they are bacteriostatic in nature. But then there are exceptions to the rule. So, all these are bacteriostatic in nature, except for aminoglycosides, which is cidal in nature. And then there's another group of drugs called as streptogramins, which are also cidal in nature. Streptogramins. Okay. Now, out of the drugs which inhibit the metabolism, so these are like, for example, sulfonamides, trimethoprim, individually, they are static, right? Static if you take them individually. But when they get combined together to form cotrimoxazole, this cotrimoxazole is cidal in nature. Then, similarly, metronidazole also is cidal in nature. Ciproflox, fluoroquinolones, they are also cidal in nature. So all these drugs, these anti-cancers and all, so they target the various cell cycle phases. Again, they kill the cells. So these are the important drugs and their groups, how they are targeting the various sites on the bacteria and whether they are cidal or static in nature. So moving on to the first point here, what we are going to do is the cell wall synthesis inhibitors. So in the cell wall synthesis inhibitors, many a times you are shown this particular diagram, and this is like how the formation of the cell wall synthesis occurs. Now this is inside. You see the cytoplasm written here? So this is inside the cell. From inside to outside, if we go and follow, the step number 1 is blocked by phosphomycin. This is step number 2 by cycloserine. Step number 3 by bacitracin, step number 4 by vancomycin, and step number 5 by beta-lactams from inside to outside. So, what are these drugs going to do? So, they are going to block the first step and from first to fifth, the last step, right? This is how they're going to act. So, easy way, or let's say there's a mnemonic to remember from inside to outside. Remember, first cycle, बाद में is an Hindi word which means later on. बाद में, van, then Land Rover. So this is how we progress in life. First we have a cycle and then we progress to van and then to Land Rover. So what does this mean? First stands for F, that is phosphomycin. Phosphomycin. Cycle stands for cycloserine. बाद में B stands for bacitracin. 1 stands for Vancomycin, and Land Rover stands for beta-lactams, land. Okay. So this is how you remember from inside to outside. So in case you're asked to identify, they give you a site and they ask you to identify which particular antimicrobial acts on this particular site. Remember the sequence. Remember, this is from inside to outside. If it is from outside to inside, the sequence would change. All right, so let's do the mechanism of action of these drugs. So if I begin from inside, let's begin from the lower one first, because this is number 1 step, number 2, number 3, number 4, and number 5. So phosphomycin prevents the first step. That means it prevents, see here, the conversion of UDPG to UDPM. Prevents the conversion of UDPG to UDPM. So the first step in peptidoglycan synthesis, right? It's the first step. Now, use of phosphomycin currently is just used for urinary tract infection. Single dose UTI, that is the only use of phosphomycin. Moving on to the second drug, which is cycloserine. What is the step here? See here. Now, cycloserine, it blocks the conversion of L-alanine to D-alanine, which is we need D-alanine for formation of the peptidoglycan wall. So D-alanine is not formed. So it blocks it prevents the conversion of L-alanine to D-alanine. That is the second step it blocks, right? So where it is use of cycloserine is only in case of MDR tuberculosis. Okay. Coming to bacitracin. Now, bacitracin is a topical drug mainly. Right? So where do we use this bacitracin? So here you see the step bacitracin. This bacitracin, it is going to inhibit this BP. This stands for bactoprenol. Now, this is responsible for carrying this peptidoglycan chain towards outside. So this is because you need to have the synthesis on the outer side. So this whole chain is carried with the help of BP. So this is the BP is bactoprenol transporter. So what does bacitracin do? It blocks the bactoprenol transporter. Therefore, it inhibits the transfer of peptidoglycan chain. Okay, stops this peptidoglycan chain from transferring outside. That's the role of bacitracin. Coming on to vancomycin. So what is vancomycin doing? It is inhibiting this particular step here, where it binds to the D-alanine, terminal D-alanine, and doesn't allow it to cleave, right? So because it is important that it leads to, this D-ala cleaves, then there is a release of energy, and then there is actually the formation, the cross-linking, then later on by happens. But this is going to block that first step. It doesn't allow the D-alanine. It blocks the D-terminal D-alanine here. So what it does, it blocks or it attaches to the terminal D-alanine and it inhibits transglycosylation. Right? That is the most important. So it is one step before the beta-lactams. Then the terminal step is beta-lactams. So beta-lactams, they bind to the penicillin-binding proteins and inhibit the transpeptidation. Remember, they inhibit the transpeptidation and cross-linking. So if there is no cross-linking formed in this particular the cell wall, then they become very weak. The cell wall becomes very weak and it is easy for the cell wall to get destroyed. And therefore, and cross-linking. So beta-lactams consist of your penicillins, cephalosporins, carbapenems, and monobactams. So this is the main role or main mechanism of all these drugs which act on the cell wall, remember, right? So these are the drugs. The first one, beta-lactam. So we have the penicillin G. In the penicillin G with the aqueous form, we have the aqueous penicillin G. We have the procaine penicillin G, which is highly notorious to cause the hypersensitivity reactions. And then we have benzathine penicillin G, which is the longest acting out of the lot. Now, uses of penicillin G, remember a mnemonic here, which is mega drills. DR or drills, we can say. DRALS, mega drills. Okay, so let's see what are these mega drills. So M stands for meningococcal meningitis. So we use this drug as the definitive treatment. For prophylaxis, or you can say for the empirical prophylaxis, we use ciprofloxacin. We can use rifampicin in case of pregnant and women and in children because fluoroquinolones are contraindicated in them. So rifampicin in pregnancy and in children. Then E stands for endocarditis. Streptococcal endocarditis. So here you usually give it along with an aminoglycoside. So beta-lactams are going to cause the breakage, or it is going to cause non-formation, or it doesn't allow the synthesis of the cell wall, and easier for aminoglycosides to penetrate inside. Also, if you see the spectrum, beta-lactams like penicillin, they are most effective against gram-positive, while aminoglycosides are more effective against gram-negative. So that is another thing in there. Then G stands for gas gangrene. Then A is anthrax. D is diphtheria. R is rat bite fever. A is actinomycosis. L is leptospirosis. And S is syphilis. Now, ampicillin, where it is used? So, ampicillin is used in case of listeria monocytogenes. Right? It is the drug of choice here. Amoxicillin in respiratory tract infections and also in some urinary tract infections. Now, very important is treatment of syphilis. Now, remember, depending on the stage of syphilis, we treat primary, secondary, early latent syphilis, late latent syphilis, and tertiary syphilis without involvement of any organ. So, no neurosyphilis, no other organ is involved. In both of these cases, we can use the benzathine penicillin. So, here we use injection benzathine penicillin. Here also we use injection benzathine penicillin. You know, they have a longer half-life. So, longer acting also. So, here in the first case, we use injection benzathine penicillin, 2.4 units intramuscular, but single dose only. In the second case, we use 2.4 million units intramuscular once a week for about 3 weeks. So, we use 3 doses. Now, in neurosyphilis, we can't give benzathine penicillin because we need it to enter the brain. So, here it is no longer effective. So, we use here aqueous crystalline penicillin G, 18 to 24 million units, and you give IV daily. Remember the dose here also for syphilis. Now then we have semi-synthetic penicillins. Now obviously because in the penicillins have a lot of drawbacks, orally they're not very effective, then there is resistance occurs, and acid, they are labile. So what we have done is we have created certain semi-synthetic penicillin which can actually address each of these issues. Now, acid-resistant penicillins that we have, you can say they are classified into various drugs, and we remember a mnemonic: vodka. So here acid-resistant penicillins. So we have penicillin V, O is oxacillin, D is dicloxacillin, C is cloxacillin, A is ampicillin, and the other one is amoxicillin. So even single I can write as the aminopenicillin. Now, extended spectrum. So these are your extended spectrum. So again, another interesting way to remember this is, where you remember that they work against extended spectrum against 3 microorganisms. One is Klebsiella, Pseudomonas, and E. coli. So let's see, starting from the first organism, which is your Klebsiella. So against Klebsiella, MAP mnemonic that you remember. So here in the uridopenicillins, we have piperacillin, we have meslocillin. Also, you can add another one, that is azlocillin. Azlocillin. So MAP stands for, so this is MAP, M-A-P. Now this is effective. So these 3 drugs, they are effective against Klebsiella. Now, CT-MAP, bring in more penicillins here. CT is this one, CT. So CT-MAP is now effective against pseudomonas. Right? So this was only effective. So this is MAP, this is CT-MAP. And then bring in aminopenicillins also. So this is ACT-MAP. So A here stands for the aminopenicillin. So this is effective against E. coli. Easy way to remember, MAP is against the MAP. The drugs are against Klebsiella, that is meslocillin, piperacillin, and azlocillin. CT-MAP, that means MAP plus CT, carbapenems, ticarcillin, also against pseudomonas. Then you add A, aminopenicillins, they're also all effective against the E. coli, right? So this is the way to remember these drugs. All right. Then we have beta-lactamase inhibitors. Now, what are beta-lactamase inhibitors? We know that many organisms, they now secrete beta-lactamases. So these are going to destroy the beta-lactam antibiotics. So resistance develops to these drugs. So what we do, we give beta-lactamase inhibitors along with these drugs. So for example, with amoxicillin, we give clavulanic acid. With ampicillin, we give sulbactam. With piperacillin, we give tazobactam. And tazobactam is also being given with a cephalosporin, which is ceftolazone. So what is the role of these beta-lactamase inhibitors? They are not antimicrobials as such. What are they? These are called as suicide inhibitors. So they are suicide inhibitors. Their role is just to inhibit beta-lactamases so that the antimicrobials, they can do their role. So they just inhibit the beta-lactamases. They are suicide inhibitors. So why do we have a particular beta-lactamase inhibitor with a particular beta-lactam antibiotic? Is because they have some matching pharmacokinetics. That's why they are used. Then we have some newer examples of these drugs, suicidal inhibitors along with beta-lactam inhibitors along with the other drugs. For example, with meropenem, we have viborbactam. With ceftazidime, we have avibactam. And with cefepime, we have enmetazobactam. So these are the some newer combinations which are in market, and you should be knowing about them. All right. From penicillins, we move on to cephalosporins. So cephalosporins are classified into 5 generations. So remember, here in 5 generations, the first generation, they usually end with Pha or PHA or FA, right? Most of them, they have in the spellings either Pha or PHA. Exception to the rule is cefaclor. It is under second generation, even though it has a Pha in that, but it doesn't belong to first generation. That's the only rule. Second, don't need to remember. You move on to the third one. In the third ones, they end with either 1 or 10 or I. 1, 10, I. So they end with this. So ceftriaxone, ceftibuten, ceftazidime, cefpodoxime, cefixime, cefoperazone, etc. Then fourth generation, they have pi in their spellings. And the fifth ones, they have rho in it. That is the, anything which is left, it will belong to second generation. Remember, the second generation drugs, these are not used. Clinically, they're not used. Okay. Now, from first generation to the fifth generation, the spectrum also changes. So first generation is mostly effective against gram-positive organisms. So as you move on, the second generation, they have more effect against gram-negative. Some are even effective against pseudomonas. Fourth generation also, they are quite effective against pseudomonas. Then fifth generation, these are the only beta-lactam which are effective against MRSA, right? So from gram-positive to the varying organisms like pseudomonas, even ESBL, so they are effective against them. Now, out of the first generation, the important drug that you have to know is cefazolin, which is a drug of choice for surgical prophylaxis. Okay. Then third generation, the most important drug groups here. Now, cefixime, this is the oral drug of choice for typhoid, while ceftriaxone is the IV drug of choice for typhoid. So ceftriaxone is a very, very important drug. So it has other uses as well apart from typhoid. It is also used in meningitis as empirical treatment. Remember, this is an empirical treatment. Penicillins are the definitive treatment, and with prophylaxis, we have ciprofloxacin or rifampicin. Remember that, right? And also they are used in, drug is used in gonorrhea. Okay, so these are the important points here from the group. Now let's do some other classical examples that are asked, or the points which are asked. Which cephalosporins are effective against pseudomonas? So the drug of choice, we have ceftazidime, and we combine it with an aminoglycoside in case of severe infection. The other drugs which are effective against pseudomonas, we have from the third generation is cefoperazone. From the third generation, we have ceftazidime, cefoperazone, which is effective. And the fourth generation cephalosporins, both of them are effective. Right? And we've done a combination here, ceftolozane and tazobactam, this one. This is also anti-pseudomonal. So tazobactam with ceftolozane. So tazobactam with ceftolozane. So all these are effective against pseudomonas. Then which of the cephalosporins are safe in renal failure because they're secreted in the bile? So again we have ceftriaxone and cefoperazone. Ceftriaxone also causes pseudolithiasis. Then disulfiram-like reaction or hypoprothrombemia, it is caused by cefamandole, then cefoperazone, then cefotetin, and moxalactam. Moving on to the next group here in the beta-lactams, we have carbapenems. So in the carbapenems, we have meropenem. So all these will be penems, meropenem, imipenem, itapenem, doripenem, ferropenem. So their spectrum, if I talk about, they have a broad spectrum. So they are effective against gram-positive, gram-negative organisms, pseudomonas, ESBL, as well as ANV. For these serious infections, we give them. Now, Ertapenem is the only carbapenem which doesn't have a good activity against pseudomonas. So we can say this is not very active against pseudomonas. Not active against pseudomonas. Ferropenem is the carbapenem which is available by the oral route. Others are parenteral. This is the one which is available by the oral route. Now, imipenem has a very short half-life because it gets degraded by dehydropeptidase. So, if you give imipenem as such, it will be immediately degraded with have a short half-life. So, what do we give? We give it along with a drug called as cilastatin, which is inhibitor of renal dehydropeptidase. So because of this, it will prolong the half-life of imipenem. So what will happen? There will be increase in the half-life of imipenem. It's not required with the others, but with imipenem especially it is required. Other problem with imipenem, what is the other side effect or the adverse effect with this imipenem is that it can cause seizures, right? Seizures is one of the important side effects. Then monobactam. So monobactam is different from the other beta-lactams because it has a single ring. Single beta-lactam ring. The name is estrionam. Because of this, there is no cross allergy. So if you give a beta-lactam and patient develops allergy to that or hypersensitivity reaction to that, you cannot give any other beta-lactam except for monobactam you can give because it has a structural difference from these beta-lactams and can be used in case of if there's an allergy with those drugs. So it has no cross allergy as such. But remember, its spectrum that it is only for gram-negative organs. That you have to prove. Now coming to the various drugs for MRSA, methicillin-resistant Staph aureus. So remember what happens is when you give a beta-lactam drug, so bacteria, they are intelligent, they start developing or they are making beta-lactamase to escape attack from beta-lactams. Now for beta-lactamase, we made drugs like methicillin, right? Or cloxacillin, all those drugs. But organisms develop resistance, they formed methicillin-resistant Staph aureus. Then for this, you made a drug, Vancomycin. But organisms, they became more intelligent and they developed vancomycin-resistant Staph aureus. Now for this, you have two types of treatment. So you give two types of drugs. One is daptomycin. You can give it, but if it is VRSA associated with pneumonia, then you can't give daptomycin. Then you give linezolid. You can't give in pneumonia daptomycin because what happens is there is degradation of this daptomycin by the surfactant in the lung. So it won't be effective. So you give linezolid. So this is a table that you should know. So here for MRSA, IV vancomycin is the drug of choice. We can give other drugs like, so other drugs which we have, we just now did that 5th generation cephalosporins can do the trick. Then we can give linezolid as such. We can give teicoplanin also, and we can give streptogramins. Topically, for this MRSA, you can give mupirocin or bacitracin. For VRSA, I said drug of choice is daptomycin. But in case of pneumonia, we can't give daptomycin. So here you will have to give linezolid. Then for extended spectrum beta-lactamases, what is the drug you can give? That is carbapenems. Carbapenems. Then if bacteria develop resistance to this as well by forming carbapenemase, what can you give now? You can give tigecycline or polymyxin. Okay. So what are the different drugs used for pseudomonas? Important. So the drug of choice you have discussed, aminoglycosides plus ceftazidime. Then you can also give colistin. You can give polymyxin B. Then we have various fluoroquinolones which you can use. Ciprofloxacin. We can use levofloxacin. Then we can use carbenicillin. We can use ticarcillin. We can use piperacillin. Okay, then we can use carbapenems. We can use monobactams. We can use fourth generation cephalosporins, right? And we can use cefoperazone. So these are the drugs which can use for treatment of pseudomonal infections. All right. Coming to another very important topic, it is vancomycin. The vancomycin was blocking the step just before the beta-lactams. So where do you think we can use them? So it is used only in case of a condition which is called as pseudomembranous enterocolitis. So this is a picture which shows pseudomembranous enterocolitis. This is caused by an organism. It's an opportunistic infection or superinfection and caused by the organism Clostridium difficile. So which are the drugs which have more tendency to cause this infection? So we have third generation cephalosporins. Then we have aminopenicillins and clindamycin. So they have a tendency to cause this. The drug of choice which we have for this condition is fidaxomicin. We can use vancomycin, but the drug of choice is fidaxomicin. We have some newer drugs also like bezlotoxumab and ridinalazole. So these are the newer drugs that you should know. Vancomycin IV. So this was orally when we use by the oral route. So where do we use for the IV? We just now did for the MRSA. We use it and even for toxic shock syndrome. Right? So what is the drug used for prophylaxis of MRSA? So here we use topical mupirocin or bacitracin you can use. Bacitracin. Now remember, vancomycin is not effective against please remember, it is not effective against pseudomonas. Most common side effect which is seen is a maculopapular rash. Maculopapular rash. Now, vancomycin, if we give it very fast by IV route, it leads to a condition called as red man syndrome because of the release of histamine. So because of the release of histamine, so when you give very, very fast IV infusion, it appears within 4 to 10 minutes. So how can you prevent it is by giving IV infusion at a slow speed, right, over a period of time. Or you treat with an antihistaminic drug. So, or you give treatment of beforehand only you give an antihistaminic and it definitely needs dose reduction. So this is the condition, this is called as red man. So you see the redness, the whole patient, he turns red, he or she. So this is called as the red man syndrome. It can be an image-based question as well. Then currently or no, lately it was asked what is the scale for vancomycin dosing. So just remember the scale. It's called as Matske normogram scale. Okay. Now, drugs acting on the cell membrane, we have daptomycin. It forms pores on the cell membrane and leads to potassium ion efflux. So this is a drug of choice for VRSA, except pneumonia, right? Except pneumonia, where we give linezolid. It is also used for VRE infections. Colistin is used for a condition which is called as superbug or New Delhi metallo beta lactamase, right? Organism is New Delhi metallo beta lactamase. It is used in the superbug. It is used, and it can also be used for pseudomonas. So basically, it's used for multi-drug resistant gram-negative bacteria. That's the role of or use of colistin. So with this, we finish with the drugs acting on the cell wall synthesis and the cell membrane.